people who are watching us on Capital TV this afternoon. My name is Representative Raymond Hull, Chairman of the Corporate Task Force. It was established by now Speaker Sakatri. It's designed to get some answers and try to figure out what's happening in this pandemic so that our constituents are adequately informed and that we do what we're supposed to do, our due diligence for the people that we serve. Uh, some just some rules. If you're not speaking, mute yourself. When you go to speak, remember to unmute yourself. Today's meeting, I anticipated to be a little bit uh, contentious because we're now in the heart of the pandemic. We're hearing from our people. I understand. I feel their pain, their frustrations. I want to make sure we get the answers to the people who are asking us. Most of the people right now have probably had calls, numerous calls, because I have some. So we will get them the answers the best we can. I want to be upfront with them. I don't like to lie to people. I don't like to put them off, nor will this committee while I'm chair. With that said, if you could just raise your hand for this first speaker, I will identify, I will get to you. Don't think I don't see you, because I can see everyone here. And unless you want to use your hand, put your hand up on the chart there, the little thing on the side here. But nevertheless, just put your hand up, I can see it. With that said, I'm going to open it up to Dr. Scott first, to just give us some idea of where we're at. Or maybe that it shouldn't be Dr. Scott. Maybe it should be, I don't know.
I'm ready. I'm
Okay.
ready. It is me.
Good.
I'm
Thank you,
thankful
Dr.
to have our team with us as well. So Neil Heitinen, as all of you know, our legislative liaison extraordinaire, as well as Dr. Phil Chan and all of our superheroes, Alicia Maholicus and Trisha Washburn, who have been valiantly leading this vaccine response as our public health experts, along with very many other members of the team, operations leaders, such as Dr. Hawkins and so many others that we're grateful for. So to start, can everyone hear me well enough, Chairman?
Yes.
Is this working? Okay. So I'm thankful for the opportunity to update on where we are and help equip all of you with answers to the questions that all of us are getting. The bright side of the pressures that everyone is feeling is that it is an indication that we have a significant proportion of our population that is interested and willing to get vaccinated, and that's absolutely what we want. The number one message that you will hear through this discussion is as soon as we get the supply, we'll be able to respond to all of those needs for getting vaccinated. And any support that you can do to both help make that message clear and help encourage the increased supply, which is what's so critical, is welcome in terms of the partnership. So to jump right in, we want to reiterate that our guiding principles are to make sure that vaccine safety is clear. And that's really what's exciting about the fact that so many people are, eager to get vaccinated, and it's coming through as frustration, but it does remind us that folks are understanding the vaccine is safe. It's gone through the safety standards. No steps have been skipped, continuing to message that so everyone who ultimately does get access to it takes advantage of that. We also have minimizing morbidity and mortality as a primary focus. We really want to use the vaccines to help prevent hospitalizations and to save lives, to prevent deaths. That is a critical category that is distinct from the equally important ability to stop transmission of COVID-19. Um, we want to, particularly given the limited supply, we want to really focus the vaccines on saving lives and stopping hospitalization so that we can preserve our healthcare system capacity and not have it get overwhelmed. In the meanwhile, to stop transmission, we need your help in continuing to promote mask wearing, which stops transmission, hand washing, and distancing effectively. So there are younger members of the population who are otherwise healthy, but adults and going to work who are at risk of getting COVID-19 through transmission, but are at significantly lower risk of actually being hospitalized or dying from COVID-19. So we are choosing to focus, particularly with the limited supply, our prioritization on those who are hospitalized, at risk of being hospitalized and at risk of dying, and encouraging those other populations that are at much lower risk of that. We will get vaccine eventually to you, but in the meanwhile, keep wearing your mask, keep distancing, and keep washing your hands. We are also focusing on an efficient distribution of vaccine so that we are overcoming the very complex logistics as effectively as possible and making sure that access to vaccines is optimal. And so, with that, equity is our primary focus across and undermining all of these guiding principles. We really want to focus which are the communities that are most disproportionately impacted, and how can we ensure that from our distribution standpoint, each time with each priority group, we are targeting those communities that we know have been hardest hit disproportionately. So your partnership and leadership in helping to ensure that that happens is also welcomed and critical. The next slide will get into where we are for phase one. There are approximately 200,000 individuals overall in phase one. And I really want to pause on that statement because it really is the premise for what you started this conversation with, and really wanting to bring the truth back to your constituents. We have a priority group of 200,000 people at least for phase one, and we are getting 14,000 doses a week of vaccine at most, if that. That's like what we are anticipating. Sometimes we do, sometimes we don't. So reconciling those two large numbers is why we are all experiencing this very appropriate frustration of, I want to get vaccinated today, I want my parents vaccinated, I'm concerned about this individual or that individual. We want to respond to that as well. We have to work together on addressing this gap. What was stated yesterday in the national news did not help us in addressing this gap. The fact that all 65 years of age and older should get vaccinated immediately is something we absolutely want to do too. That's an additional 190,000. That would make this group almost 400,000. We are still getting 14,000 a week. That's our number one key in knowing where this challenge is. It's not a Rhode Island approach issue. It's not a distribution system issue. It is fully a supply issue. So phase two estimates are pending further population refinement, which we will do. And certainly, as noted, in addition to operations and logistics to carry it out, phase two will also be dependent on our supply in terms of when we receive it and when we can get started. So this timeline gives you a sense for phase one that, each group, as we get started with group 1.1 and go to group 1.2, we're not waiting to complete one group to get started with the next group. For example, even as of Today, with 1.4, we're going to start getting started earlier than what's here, because we don't need to complete one of the phases for 1.1 and 1.2. As we get the supply, we want to start pushing it out. So our focus is to um, use any of the supply we need to help inform how long it actually takes us to get through phase one. If there's a responsible increase in the supply from the federal government for both the first dose and the second dose, we will be able to accelerate the timeline. If it continues to be slow and linger, it will take this at best or longer. Okay, thank you, Neil. So phase one population is broken down based on what you see here. And a few things I will call out is the fact that the pharmacy partnership has been set up through the federal government. And so the actual management of that distribution is not controlled by the state. It is controlled through our federal partners working directly with CVS, Walgreens, and the nursing homes and subsequent uh, partners. We are helping to ensure it's happening and overseeing, but not the responsible party at the state level managing that. What has been required from the feds is that we allot a certain amount of our vaccine supply to that pharmacy partnership in order for them to know that they can do the required 3 visits that will be needed for each of the nursing home and other congregate setting sites that they will go to. Because Rhode Island has a larger proportion of our population that's in the older community, including in nursing homes and residents, we have had to put aside a larger proportion of our already limited vaccine supply to go to this pharmacy partnership to ensure that the feds have what they need to manage that getting out to the seniors and other congregate settings at higher risk. So that's an important message to know. Even though we're getting 14,000 a week, proportion of that already is committed to the pharmacy partnership and addressing the seniors and other congregate setting residents and staff. And then I will also add what I said a little bit earlier, in that we are looking to be as innovative as we can be to address the priority groups that are here. Our outpatient primary care providers who are not already working in urgent care and respiratory clinic settings, or already swabbing people for COVID that were already taken care of or are being taken care of in 1.2, we are moving the 1.4 group of outpatient providers to getting started in vaccinating a week earlier than we originally had, because we're understanding the importance of helping to respond to that priority group: outpatient providers, dentists, behavioral health care providers. And we know, because that group is so large, it's going to take time incrementally to be able to get it to them. So thank you to our partnerships with some of our other providers. We're being able to help direct some of the vaccine a little earlier than anticipated to some of the outpatient providers. And then our next major group is individuals older than 75. And were we to get enough vaccine supply, we would actually absolutely expand that to individuals over 65, which makes up over 190,000, as I mentioned, of our population. So the next slide tells you who we have vaccinated during the week of January 11th, this current week. And so it's a reflection of the fact that although we started with group 1.1, we are already extending into 1.2 and 1.3, not waiting to complete one to go to the next. And this next slide gives you who, well, we have also the list of who we anticipate vaccinating in the week to come, which extends into 1.4. So for vaccines administered to date, we've received 72,000 actually in the state. 16,000 plus of that has been committed to our long-term care facilities. And when you look at the vaccines that we have direct management and oversight over, 55,000 doses has been received and 50,000 have been distributed. So that's at the 90% mark. What we've gotten in and we control, we get out and make sure that they are distributed and ultimately administered. And so that's a key message and hopefully something that you can relay to constituents who are wondering, is vaccine just sitting around or getting wasted in any way? There's absolute confidence we're doing everything we can to push out whatever we receive. And the more we get, the more we'll be able to push out. So we are receiving 14,000 a week. In general, we are vaccinating about 2,000 a day. So over the 7 days, what we're getting in, we're in general making sure it's distributed out to be vaccinated during that week. We keep it in a pool as we get it because once it's received, it then has to be redistributed to the right location. And then those that are administering have to schedule individuals because we can't just have everyone show up to one clinic in this pandemic response the way we were able to with the H1N1 pandemic response because of the risk of spread. And so that takes time between a dose actually received and then when it's actually injected into someone's arm. But our systems are such that what we get is equivalent to what ends up going out that same week. Next slide. This captures for you graphically how it is operationally complex.
And should be all
Okay. Yeah.
I lost something on the screen.
The fact that a dose is received on one day, this demonstration here shows that it's not actually administered that exact same day. The process begins with the federal government releasing at the beginning of a week what they are going to allocate for that week to us in the state because it can change each week. That's part of the challenge of how complex and dynamic this is. So first we learn what we are actually going to be allocated. Then we have to order it, which we always do immediately. That's no question, no time is wasted there. We order our full allocation. Then we have to wait some time to actually receive it. And so even though the CDC may say this is what they've distributed, there's still a gap between when we actually receive what has been sent out. There are some scenarios where what's been received goes directly to one of the larger locations that can distribute it and administer the vaccine. But there's also many scenarios where we receive it at the state level to a centralized location and then have to take the few days needed to redistribute it to the more local sites effectively. And then those local sites have to ensure that they are scheduling it, they have the contact information, and are bringing those individuals in to safely administer the vaccine. So this process from beginning to end can take up to 2 weeks time frame if needed. And so our focus is whatever amount we're getting in, that's the amount that we're getting out. And we have a strong system in place to ensure that that happens. So I'll spend a few minutes talking about equity considerations so that it's clear This is an element that we're not just talking about, but are embedding into our operationalization. We recognize that equity plays a key role for us in both the prioritization and distribution of our vaccine strategy. There are data and science driven reasons for that. We know that there have been groups disproportionately impacted by COVID 19. And as I mentioned earlier, we have hospitalizations and deaths as a driving factor. When you look at the populations within our current priority groups, those who are in long term care facilities are at risk of being hospitalized 21% of the time. Those who are in our more densely populated communities are at risk of being hospitalized also double-digit percent of the time, up to 14, 15%. Those adults in our lower risk population, otherwise healthy, their risk of hospitalization, single digits, 4%. They are still at risk of transmitting or being infected by COVID 19, but their risk of hospitalization and ultimately death is significantly lower than the other populations that are in our priority groups. And so we want to ensure that these initial limited doses of vaccine are going to what's going to get us the highest yield, what's going to save lives, and what's going to keep our hospital capacity strong and keep our system from getting overwhelmed. Those are the population groups that are driving our prioritization. The other lower risk, healthier groups, we want keep masking, keep distancing, keep washing your hands. And after the lives are saved and the hospital capacity preserved, once we have enough supply, we will be getting vaccine because we want the entire population ultimately vaccinated once we have enough. So Hispanics, Latinos have been the most likely racial ethnic group to have contracted COVID 19 compared to the other portion of the population. Um, Black and African Americans have been the second most likely. And that then results in higher rates of hospitalizations and ultimately, unfortunately, that can contribute to deaths. And so we have taken the approach of our more densely populated communities that have a higher social vulnerability index, which is a calculation driven by the CDC based on social factors from census data, are our groups that are at higher risk of hospitalizations and disproportionate impact from COVID 19. And so that's why across all of our priority groups in phase one and any subsequent phases, we want to make sure that we are addressing the inequities that exist in our high density communities by looking at those who have been disproportionately impacted. So with that, I'm going to say go to the next page, please. So we've used the recommendations regarding equity that have come from our outstanding COVID 19 vaccine subcommittee. They've been a fully engaged group of experts who we've worked closely with, has provided tremendous feedback and input that has been extremely valuable during this response. We also have other key advisors throughout the state that have helped inform our decisions regarding vaccine distribution to date. And so from an equity standpoint, we've made sure that that's embedded in our guiding principles. We've made sure that we are incorporating targeted high density communities in our approach so that we can have the best yield for minimizing hospitalizations and deaths. We've started with Central Falls, and then we'll be preparing to engage the next um, uh, set of zip codes with high density communities, and have also focused on making sure that there is the demand in overcoming the concern or hesitancy. We want these communities to understand that this is about saving lives. Usually, people from certain high density communities are ones who are more on the front lines, either in a healthcare setting or some other work setting where they have to be out and about. And particularly those who are older or have comorbidities that are more likely to be hospitalized. This is why the vaccine is available for you. And as we go forward with more supply, we want to make sure that everyone takes advantage of that. Okay, Neil. This is to show you some of the zip codes uh, that have been experiencing the higher Rhode Island COVID cases and the higher rates of cases per 100,000 population. And so you see Central Falls is the 02863 zip code, that even though um, their cases have been 3,385, because of the size of the population there, when you look at it as a rate per 100,000, their rate is the highest out of all of the zip codes. And there are many others in Providence and Pawtucket that's included. And that also is mirrored with what we are doing when we are testing, looking to test as much of the population in each of the municipalities as possible in a targeted way. And as you see again, Central Falls has the highest percent positivity. The more who test positive, and the more who have some form of underlying illness, the higher the risk of hospitalization. And that's what the vaccine is intended to help us prevent and minimize and be able to preserve our healthcare system capacity. This also, very importantly, emphasizes the fact that when you look at our Hispanic and Latino communities, which is the top blue bar, and our Black and African American communities, African communities, that is the yellow bar, the proportion of these groups that are hospitalized with COVID-19 are not only significantly higher than other race and ethnicity groups, but also starts much earlier in age. 30 to 35, 35 to 44, 45 to 54, compared to some of the other groups where it's the older population only that are experiencing the hospitalization risk. And that's why we have to take a comprehensive approach. If we're looking to preserve our healthcare system capacity, minimize and prevent hospitalizations, we have to look at how populations are being impacted by COVID-19 in the best way that's going to lead to minimizing hospitalizations and saving lives. And when you adjust for age, you see that difference uh, uh, go away to the same extent, but it still is impacting younger uh, age individuals when you look at African Americans and Latinos, and also see how much higher the rate is of COVID-19 deaths, unfortunately. To finish with this discussion, I'll talk briefly about our phase 2 prioritization. Vaccine supply, as I said, is our number one issue. We get more vaccines, all of us will have a different experience with the constituents and community members that we serve and what we're hearing from them. We are taking every measure to provide the vaccine as safely, as equitably, and as quickly as possible. And I hope you come away from this presentation with an understanding of all of the operationally complex steps that we are taking to make sure that happens. And as additional COVID-19 vaccines get approved and more supply arrives, you can be confident that we will get those supplies out. There are no vaccines sitting on any shelves for any period of time, no vaccine being wasted of any significant amount in any period of time in our state in Rhode Island. I shared earlier today the experience I had in helping my mother, who's over 65, living in New York, get vaccinated, because their announcement was everyone over 65, just go ahead and get vaccinated. She thought she'd be able to. We looked at slot after slot. Everything is full. So they're saying you're eligible, but then when people are actually going, it's causing more frustration, more confusion, because there isn't anything available for weeks anywhere. And so we want to handle this responsibly. We want to make sure that when we say it's available, people can go right then and there, have their schedule set up, and get the vaccine. So that's how we're approaching it. And I know everyone is challenged regardless, but we wanted you to be aware of why we're going through what's taking place here in Rhode Island. And we'll continue to work with the vaccine subcommittee, as well as you all and our executive steering committee, to help inform how we will continue the prioritizations going forward in a way that will help us continue to be as safe and equitable and as quick as we can in distributing the vaccine. It's helpful to also express that staff and residents of group homes serving individuals with developmental disabilities will have the opportunity to be vaccinated in phase 1. Both group 1.2, where staff and residents of group homes that include individuals primarily 65 years of age and older, as well as group 1.4 in phase 1, which is staff and residents of other group homes serving individuals with developmental disabilities. That's a top priority. That's why they're included in phase 1. And as we get supply, we fully intend to ensure that these groups continue to receive the vaccination that we have planned out. Our guiding principles will continue to be followed for phase 2, where we are minimizing deaths and hospitalizations. We're focusing on equity and access so that we're prioritizing those based on age, race, ethnicity, socioeconomic status, because that translates to who is at highest risk of hospitalizations and deaths. And we will want to use the increased supply availability to help us in getting more and more of the population vaccinated, and ultimately in being able to ease up excuse me, on restrictions in the long term as we're able to do that. The next slide. This is a snapshot of what we've shown the subcommittee to help inform our thinking for phase 2. We want to take into account ways to allow us to vaccinate large groups of our population in phase 2, priority groups, as effectively, safely, equitably, and as quickly as possible. And so it involves us approaching this in a way that allows us to do that most successfully. If we look at age, the ability to reduce hospitalizations and deaths is high. To also operationalize it, the ability to do that is high. As we can easily see, when someone's date of birth is and whether or not they qualify, and the ability to message it to the population is high. when we look at occupation, there are much more challenges involved with operationalizing it quickly. The operational feasibility is therefore related as low. How are you going to decide who are all of the grocery clerks that are out there? And when people show up to get vaccinated, how do we verify that? And how do we capture and know that we're getting 100% of the population? Those types of questions are more challenging. We could and we would if we had to, but we have the opportunity to see what are some other ways to have us be just as, if not more effective, but then also operationalize easier and then communicate it more easily. Geography, particularly if we look at the communities that are hardest hit, the way we have piloted in phase one also allows for some more operational feasibility and ease of communication in being able to proceed. So this is a snapshot of how we are continuing to look at phase two and what's going to get us to the outcomes of getting everyone vaccinated as quickly as possible. So with that, I've shared with you what our goals have been, what some of the challenges are, and how we are looking at going forward. I hope many of your questions have been answered from that presentation. Thank you to the team who's done an amazing job pulling all of this together. And I'll pause there to open it up for questions.
Okay, hang on for just a second, because I want everyone to know who their representative is, because there's a lot of stuff that was put out here recently, and I want to make sure that they know who's out here representing them, because I have some questions, but I'll leave it up. I'll be there shortly. And representing District 60 in Pawtucket, Karen Alzate. Representative Michael Chippendale, District 40, Foster, Gloucester, and Coventry. Representative Kathleen Fogarty, District 35 of South Kingstown. Representative Joshua Giraldo, District 56, Central Falls. Representative Carol Hagan McAtee, District 33 of South Kingstown, Narragansett. Representative McGaw, District 71, Portsmouth, Tiverton, Little Compton. Representative Mary Duffy Messier, District 62 of Pawtucket. And Representative Norrie, District 25, Coventry and West Warwick. And David Price, representative from District 47, Boylston and Gloucester. I say that on purpose because there's a lot of information that just came out. I have some questions, but the first question I'm going to leave open to Representative Fogarty, with your first hand. And just not to throw it off, but I just want the people that are listening and watching, who's on this? That's all. And Representative Fogarty, please move forward.
Thank you, Representative Hull. My question is, Dr. Scott, obviously you've been hearing about, we've heard it loud and clear that you're only getting the 14,000 doses per week. And President Biden, when he takes over on next week, his first plan is to release all of the doses that are available. It does, I'm not sure where I stand with that, because I'm concerned about, I used to be in pharmaceutical sales. I used to sell antibiotics. I always think about resistance building up when you don't have the follow-up or the right dose of medication. I wonder about your concerns, if you think this is a good idea, because we're obviously, you seem to be upset, and I'm sure other state health people are concerned about, not upset, but concerned about the lack of, enough doses. But if he does do this, and this is his plan, what's your thoughts about that? And if that does come to the state, are we ready for a plan B to get all that vaccine that you're getting in, to get it out as soon as possible? And are we dealing with the municipalities? I'm thinking somewhat along the line of the plans that they had when we had the H1N1 vaccinations around the different municipalities a few years back. I was on the town council of South Kingston. I remember it being set up in our school systems. So just your thoughts on future President Biden's plans, and your thoughts about following directions from the manufacturer. And I noticed too, the CEO of Pfizer last night said that he was also going to have up production increases to about 20 million doses this year from Pfizer itself. So again, I know it's a lot thrown at you, but maybe you could answer it all in a succinct way. Thank you.
have a great team that will be happy to jump in as well. We would love for Pfizer to increase the production of vaccine. We're also very eager for the other two companies to push out the vaccine that they have, because it will be helpful to respond to this limited supply challenge. I agree with your concerns about automatically pushing out all of the vaccines that they have at the federal level. My colleagues and I, at the national level, in the association that I have one of the prior presidents of, have been communicating with our federal partners, expressing the concerns. There are 2 doses at this point that have been studied in terms of its effectiveness for the vaccine, and we do not have data that shows changing to just 1 dose will have the same outcome. So as of now, we're taking the approach that both doses are needed. Any of the studies that have been done were not necessarily applied to the populations that we are administering the vaccine to now, such as seniors in long-term care facilities. So we would not want to take a chance in saying 1 is enough and you're good and go, and then risk the hospitalization and mortality concerns that we're looking to prevent, and that we know we can prevent when both vaccines are given. So if the federal government chooses to just give out their second dose, what they will be doing is shifting the responsibility of ensuring that that second dose is available to us at the state level. It does not automatically mean we'll now have double the amount of doses to go out, because from a public health standpoint, until we have more data, just giving 1 dose without any information about whether or not that is truly going to be effective is actually less responsible and less effective at keeping our population healthy than administering the 2 doses that we know right now works. And the feds have promised that there should be enough for us to fully vaccinate our entire population. So we would prefer I would prefer the focus to be on increasing the supply so that we can effectively vaccinate with both doses, and the feds distribute those 2 doses to us, knowing that if we give out our 1 dose, we can be confident we're going to get a supply of the second dose each time with each individual that needs to get both vaccinations.
Okay, thank you. And will you be sending it out when we do get, maybe we do get more, will you do those municipal, do you have a plan to go out to the municipalities to reduce confusion and congestion when vaccinations are going out to the general public?
We are already engaging with our municipal leaders. We have regional pods that are set up. They've been excellent partners. Alicia and Trisha could talk all day about the great work that's going on, and we will definitely leverage that and every other partnership we have to get the vaccines out to where we have them.
Excellent. Thank you, Dr. Alexander Scott.
Representative Gore.
Yes, thank you. Thank you so much for that presentation. I really appreciate it. There was some very valuable information, and you did, in fact, answer one of my key questions, which is what percentages of the vaccine that have we been able to distribute. So I thank you for that information. A couple of things that I am hearing from people in my community is some confusion around the phase 1 information. For example, community health centers are included in the people that are currently being vaccinated, but there's some question as to whether or not that includes community behavioral health centers and mental health facilities. And what I'm hearing from the people in our community is that they are not receiving information that included in that first rollout in that 1.2 where we're vaccinating community healthcare workers. And so they're confused by that and concerned, and they're wondering where they're going to fall in within that phase 1 timeline. So that I'm hearing from that population. And the other question that I'll just limit it to 2 for now, is regarding the disabled population. And I know you had talked about the developmentally disabled population and being able to be vaccinated in group homes. But from my conversations, there is a large population that is not in the group home setting. they have caregivers that are coming into the home and are going from home to home, and so therefore further risking transmission. And so what they're asking is, will their healthcare workers who are working with patients who are developmentally disabled be included in those early phases so that they're not transmitting the virus from between communities?
Both excellent questions. I'm going to take the first one and then share with Alicia and Trisha for the second one. The first one has two answers to it. For group 1.2, where we have engaged with federally qualified health centers and respiratory clinics, we have worked to incorporate our ASUs and behavioral health link, behavioral health colleagues there who have been on the front lines and doing important work. For group 1.4, our outpatient providers, which I shared, we're going to slowly start even earlier. It includes primary care providers, subspecialists, dentists, and behavioral health care providers. So those who hadn't been included already are intended to be a part of the 1.4. And I'll pass it to Alicia and Trisha to either add or correct the first one and then answer the second one.
Sure. No, Dr. Alexander Scott, I think you captured that wonderfully for the first question. Representative McGraw, we have been working closely with BHDDH and some of the representative provider groups on the behavioral health and developmental disability sides to ensure that their outpatient providers are included in 1.4. So depending on where they are engaged, some providers go into individuals' homes, some are crossing individuals' homes and group homes. It will be moving via provider group, but they will all be covered. They are all part of group 1 for exactly the reason you stated, is because they are moving in between spaces. So there's a lot of opportunity for different exposures, and we want to ensure that we're protecting all of the folks that they're visiting.
Representative Chippendale.
Thank you, Chairman, and thank you, Director, and doctors, and all the guests we have here today. I just got one quick question that I was hoping was going to be clarified, but I'm still unsure. Is dose 1 the same exact thing as dose 2, or is it part A and part B? Are they two different animals altogether?
They're the same.
Okay, so that was just something that was obviously helpful to understand this. There is definitely, Madam Director, and I say this with the utmost respect, there's definitely a discrepancy between what you're saying and what we're seeing and hearing and what's being broadcast on the nightly news every night to my constituents and to everyone in the state of Rhode Island. Just last night, WPRI said that we had only used 47% of our 80,000 vaccines that we've received. And that we're ranking second to last in New England, only behind Massachusetts on getting those out. I don't think you can, I mean, we're not going to solve that discrepancy in this meeting, but it's important to understand that that's what people are hearing and that's what people are feeding off of.
Absolutely.
So when we look at 47% of the doses that are currently in our possession only being administered, naturally people are going to get very anxious. I am definitely going to push back on your assertion that the state is not the responsible party on the state level, and that CVS and Walgreens is. The state is most certainly the responsible party in ensuring our citizens are properly vaccinated and have it available to them. The corporate partners we engage to help us in the administration of the vaccine is a different story, but we chose them, so therefore we are responsible for them. I have a concern, and one of our guests, and I'm not sure if he was on this panel or if it was on House Oversight, that Dr. Jha had participated, and as all of the doctors have been, you've all been extremely helpful. He was as well, but he's been talking recently very publicly about wasted doses being thrown away, and you did brush against it earlier in your comments. There are doses being thrown away in Rhode Island. In hospitals, people are signing up to be vaccinated, and not everyone's showing up at that time. And when those kits are delivered, if someone doesn't show up to be vaccinated, rather than use that on someone else, they're throwing them away, and that is happening in Rhode Island. It's asinine, in my opinion, that we would adopt an approach like that. Yes, I understand once they're thawed and ready to be delivered, they must be used or they will have to be thrown out. I understand that. But if you're in a hospital setting and 200 nurses sign up to be vaccinated and 150 show up, why in God's green earth would we not go to the people who are already in the hospital and sick? And I don't care whether they're 55, 45, or 25. It beats throwing it in the garbage, because at some point in our rollout, those 45, 35, and 25-year-olds are going to have to be vaccinated anyway. We have them in a hospital, we have the doses, but yet we're throwing them out because we're not in the right phase. Unacceptable. I don't know what else to say as far as that goes. That's unacceptable. I would like to hear your response to that, though.
Absolutely. I'm glad to jump in on either of them and make corrections as we go. So I'll start with the last one. We are not throwing away any vaccines at the end of the day when there are any left over. We are working directly with the hospitals and our partners to ensure that they move to the next group. If it's happening and you know of it, please let us know, because we will address it immediately. It is our clear message. We are having regular communication. Everyone knows, because we're all experiencing no vaccine can be wasted, including our partners that are doing an excellent job getting them out. When there is something left over at the end of the day, it is being administered to the next group that's available, either within their facility or that we are able to send to their facility. That's how we are moving the outpatient providers up to get started a week earlier, because we've acknowledged that and do that. So I will firmly correct the fact and agree with you. It would not be appropriate if it were being thrown out, and it is not. And if it is, please let us know. We'll address it, and our partners will too, because no one is interested in doing that. I'm
sorry. On this, are you going to go on to the next question, or are we?
Yeah, I'm going to go back to I'm taking them from the last and going to the first.
So on the second, it is absolutely happening. This is not the appropriate forum for me to tell you where and
definitely
and
let
why.
us know. We're available to you, and we'll correct it, because everyone agrees that it should not. It is not part of our system for it to happen. I want to make sure that that's clear, and we will address it. And I'm confident that the partners we're working with fully agree that it should not happen. So I want all Rhode Islanders to know that that's the case.
Okay.
In terms of the responsible party for the pharmacy partnership, I'm able to correct the notion. I did not say that we're not responsible for the doses that are vaccinated. I said that the federal government is the one managing that process, but we are overseeing to ensure that it's being done appropriately. It's a partnership, actually embedded into the name, but we wanted people to be clear on the fact that it is engaged with the federal government. The notion that we chose them, yes, we chose, like all other states, to go with this agreement, which was a good one, to ensure that CVS and Walgreens gets the doses out to all of our long-term care and other congregate setting partners. Fully understand that we are working directly with them to ensure that it's happening. The actual logistics of managing and making sure it happens is the responsibility of those entities that are doing it, and will intervene, as we have done when the feds suddenly changed the number of doses that we were anticipating giving. We will intervene and ensure that everyone who should be getting dosed the vaccine in that high priority group gets it. And then I'll finish with the first one that you mentioned of the frustration between the numbers that you have heard and mentioned the WPRI reflected and what I have said. My understanding is that those numbers are likely from what the Centers for Disease Control and Prevention is posting on a daily basis. We are working actually now to help make that correction clear this week from a messaging standpoint for Rhode Islanders. CDC is reporting what amount of doses they have distributed and sent to the states, and then also reporting what's being administered, which is what we have reported. That number is different from what we received, depending on when it's being done, because the receipt that we get can obviously lag in time. That is causing understood frustration because they have more numbers of what's being sent out than what we have in terms of received and then distributed. So we're going to work on reconciling that so Rhode Islanders can clearly understand CDC shipping them. We're not counting them until we actually receive them in hand. And then that number is what we're measuring against distributing out. And that's where of the ones that we're fully managing and controlling, the 55,000 we have received, 50,000 have gone out, 90%, we're keeping that number high. No doses are being wasted anywhere. You can count on us having a strong system to make sure as we get them, we're going to push them out.
Thank you.
Mm-hmm.
Good. Representative McAtee.
Hi, thank you, Chairman, and thank you, Dr. Alexander Scott. I have a few questions. I don't think they're going to be too long. Chairman Craven asked me to ask you if the assisted living residents are getting the vaccine as the nursing home residents are, or if there's a distinction.
They are part B of the pharmacy partnership, our assisted living residents. And so that's anticipated in the coming week.
And I've had a few calls from nursing home patients, residents, who seem to not have, who have not received their first dose, and they have no awareness as to when it's coming. Is that, I did talk to Neil today. He told me he thought most of the nursing homes residents would be vaccinated by the end of this week, but they don't seem to know that, and I think that's an issue for these patients. I don't know if you have any comment on that.
By the end of this week, every nursing home should have had at least one visit for vaccination. And just over 55 of the 84 nursing homes thus far have had that one visit, 56 of the 84. And then there are supposed to be a total of 3 visits, so that if someone misses the first dose on the first visit, there will be 2 other opportunities to get through the additional doses. Definitely, if you have residents in nursing homes who have not heard anything, let us know which nursing home, and we can relay that information to the pharmacy partnership to ensure that they have everyone.
Thank you. One of my other questions was that we've been listening to Dr. Jahar say, and I know Kathy addressed it as well as Representative Chippendale, say that one vaccine could be enough. It's better than having no vaccine. And I wonder, so my question is, could a person go longer than the 3 to 4 weeks that are required between vaccines? If we got to that point, I guess, you know, what I'm trying to say is if we had enough vaccines, just get them out as we get them and rely on getting the second batch down the road. I believe with the new administration, it'll probably be more easily accessible to us as a state. And the question I want to know is, can you wait longer than the 3 to 4 weeks and still have the same effectiveness of the vaccine?
It's it's an excellent question, and it's actually what is driving the concern. I'll just say for a minute and then let Dr. Chan and others be able to add some more detail. We don't have any data that tells us once you go past that 3 to 4 weeks. So if immunity were to wane significantly and someone is actually exposed during that time, and we don't know when the next dose is coming, can you go 5 weeks? Can you go 6 weeks? Can you go 3 months? The challenge with that and the unknowns actually set up populations for being even more at risk. Maybe a little bit later when we have the healthier populations, but these are populations that we have to ensure are effectively vaccinated so that we can prevent the hospitalizations and deaths the way we want to. Anything else you want to add?
Okay.
Oh, thank you, Director, and thank you, Representative, for that question. The only thing I'll add is that last week, the FDA and the CDC are looking at this. It's a great question, one that we eventually hope pans out, to be honest. There's a lot of science around this, but the FDA has released guidance that we should follow the current dosing schedule. So if we were to change, we'd be going against national and clinical recommendations at the moment. So more to come on that. I think it's a great question. And the second it becomes scientifically studied and evidence-based, we'll certainly revisit it.
And I also wanted to know if we're getting any more Pfizer vaccines, or are we just getting Moderna at this point?
Absolutely getting both. We're getting everything that we can, for sure.
And I just want to add a commentary. I volunteer 1 day a week at South Road School to do testing. And to answer Representative Chippendale's question, there were 12 vaccines one night. We have a vaccine clinic going on one side, testing on the other. There were 12 vaccines one night, I believe it was around January 11th, or no, I think it was even earlier than that, went out and they prioritized those people in the testing room that were in the priority list in accordance with what you, Dr. Alexander Scott, have put out about who comes first. So all 12 of those vaccines were given to people in the age groups, in the priority list, and they were not wasted. So I was there, I saw it. So it does work that way. Thank you very much.
Thank you. And Doctor, if you could, and if there is, because remember, there's people watching here, some people are very, very scared to think that they are throwing it away. Would you give us some reassurance, find out, talk to Representative Chippendale? I'm not saying it's happening. I don't want to know that it's happening. I do know people are scared. That's all. And to hear something like that, it scares me. But nevertheless, we'll go to Representative Joshua Giraldo.
Thank you, Mr. Chairman. Thank you, Dr. Alexander Scott, to you and your team for a very precise and informative breakdown of the equity considerations. I really appreciate it, and I think it's important to look at the data and follow the data, especially around Central Falls. I hear lots of conversations happening, and it's great to have that data available to be able to back up why that's happening. As some of us know, it isn't that Latinos or African Americans are just generally inherently more prone to getting the virus, but also the environmental factors that play into that and really impact them. And so can you talk about what those factors are and why it's important to address those factors outside of the vaccination conversation? And I know that this has been a priority of yours, but I just want to put it out on the record as to why these sort of things happen in communities like Central Falls.
Absolutely. Thank you, Representative. It's critical to make clear that people of color, Latinos, African Americans, there's no genetic predisposition to COVID-19, to any other conditions or diseases that occur disproportionately in certain communities. Our key message has been the social and environmental factors, the conditions that someone is exposed to, represents 80% of what makes someone healthy. When we are dealing with COVID-19, this is just yet another example. When we have communities that have been experiencing higher rates of cases, higher rates of hospitalizations, and deaths, particularly based on race and ethnicity, you can look at the fact that many of the individuals are people who have been on the front lines working. They don't have the ability to stay home and work remotely. So by nature, they are more naturally exposed. They are the healthcare workers who are in our long-term care facilities. They're in our grocery stores. They're in other retail and other critical places that are keeping our society going and open, exposing themselves and their families day after day. They're also coming from multi-generational homes. Grandma's in the house, the grandkids, the working adults. We have seen the most significant risk of transmission of COVID-19 is from household transmission. When you're sharing a bathroom and sharing a bedroom, it's just challenging to maintain 6 feet of distance 24/7, wearing a mask indoors 24/7 to prevent transmission. And so we're seeing higher rates in communities where you have multi-generational families living together. And then because of the environmental conditions, the education may be disadvantaged, the access to fresh fruits and vegetables, the access to safe physical activity, walking, getting around in the community, quality housing. Those are the determinants of health that we talk about. When those conditions are of less quality, less resourced, disadvantaged, you have individuals who are more at risk of not only challenges for themselves, education, economic or other opportunities, but then also have higher risks of underlying health illnesses. If you don't have a grocery store that's going to get you fresh fruits and vegetables and access to that, diabetes is going to be more of a challenge because all you have access to are, poorly processed foods that are less expensive for you to be able to buy. So if you have individuals with more diabetes and underlying heart disease and other challenges, that also increases your risk for hospitalization or death with COVID-19. So there are cumulative factors disproportionately impacting certain populations that are playing out into why we are having higher rates in certain communities of color. It is not connected to just the color of their skin or some genetic predisposition. If we took any population and put them in those settings, you also would have higher rates of COVID-19 hospitalizations and deaths in those scenarios. So our understanding of that allows us to, one, be deliberate in how we're approaching it with vaccination and testing and treatment, but then two, look at ways to fix this for the long term so that we don't continue to have this disproportionate impact on communities again and again. It's not just happening here in Rhode Island, it is happening nationally. It is time for us to do something about it. So hopefully all of us can take what we're getting from COVID-19, look at resources. We have our health equity zones initiative. We have federally qualified health centers. We have abilities to overcome this for the long term, not just related to COVID-19. And we welcome partnering with each of you to help make these improvements be sustained.
Thank you, Director Scott. Mr. Chairman, if I may, a follow-up question.
Yes.
Dr. Alexander Scott, last Saturday, I took a trip down to one of the sites that is having vaccination in Central Falls, prioritized for those over 65 years old, just to take a look and see how things were going. And the process actually was running very smoothly. But one key thing that I'd like to point out is that those doing the registration were city staff that had been repurposed. Those that were doing the vaccinations, administering the vaccinations were volunteers. Those that were serving as observers were also nurses that were volunteers. And the EMS that were on site were being paid for by the city. And so while I understand that there's small amounts of vaccinations that are coming through, when we do end up receiving more vaccinations and more people are going to be going through the process, I am really, really concerned about our municipalities that are rather strapped and relying on volunteers and city staff to be supporting these initiatives. when the vaccines start rolling in. And so can you talk about, I know that you've been working with Mayor Rivera, and I know you've been working with other municipalities, but can you talk about sort of the safeguards in place for when the vaccine starts rolling out? How can we ensure that the staff that's going to be needed to assist with this distribution is somehow made available, and that they're culturally appropriate? So, you know, having bilingual staff in Central Falls. Thank you.
Absolutely. It's a primary focus. It allows me to give an additional thank you, which I do anytime I can, to the Rhode Island National Guard, who has been invaluable throughout this entire response and helps to ensure that we have staffing that is also culturally and linguistically appropriate. But there is also the understanding that we want to ensure the reflections of the community are who people interact with when they come to get tested, to get treatment, and to get vaccinated. So our partnership with municipalities is key. We've had creative ways to help support and resource that approach, and intend to continue doing it. We also have the Medical Reserve Corps, who has also been an invaluable partner, will engage with us directly during H1N1, is continuing to be with us at our side and helps the staff and ensure that we have enough of the individuals in place who are culturally, and also work to make sure that they're culturally and linguistically appropriate. So I'm going to stop there and see if anyone else from the team wants to add, but we are certainly with you on that one, Representative.
Took it right out of my mouth, Director. The only other request we would make, so two things, Representative. One is obviously for any of you who have other partnerships with healthcare workers in your municipalities, who you could help build that pool of volunteers who have, again, different cultural and linguistic backgrounds, to ensure that we have an abundant pool of resources available to help other communities as we move through this process on an ongoing basis. We greatly appreciate that. And then we have provided some financial support to the municipalities as part of our baseline emergency preparedness and response process in the state, for all municipalities to participate in both either single or regional points of dispensing. And we have received some additional funding that will also be pushed out to the municipalities for future engagement of those points of dispensing.
Thank you. Representative David, please.
Thank you, Mr. Chairman. Director Scott, you've been talking about nothing's being thrown away. Can you confirm that we haven't thrown any vaccines away, or do you have a number as to how many? When you say minimal, what number has or have not been thrown away?
Representative, I asked the doctor to get back with Representative Chippendale if there is. What I'm fearful of is the message gets out that it's getting thrown away, and I want it, I need it. I don't want to send that message out. So I asked the doctor to work with Representative Chippendale to see if it's actually happening.
Well, I would imagine if it is that, I mean, it's a simple answer. I mean, either we haven't thrown any out or we have. Dr. Scott is asserting that none are. Representative Chippendale asserted some were. So I was wondering, do we have an actual number that could be definitively placed on the record as to how many have or have not been thrown away?
Doctor?
Yeah, I also want to reiterate Rep. McAtee's example of seeing firsthand that they have not been thrown out, which is what our approach is. That is the number one priority, dose by dose, making
It's not answering the question. I mean, the question, how many have been thrown out? It's not, we're trying to avoid it. The question is, how many have? Is it 0? Is it 1? Is it 2? Is it 25? How many have been thrown out?
Representative, I know what you're trying to get at. I understand that. But by you just going down this path, but there's no way out right now, let us figure that out to find out if it's actually happening. She's saying one thing, and the Chippendale saying another thing. Let's not go down the path and muddy the waters up for people who really want to get this vaccine. That's all I'm asking. I understand what you're trying to do.
If we're tracking this so closely, we should know the number.
that it is clear that no vaccine is getting unnecessarily wasted. That needs to be the number one message. When you are administering vaccines, there are times when, due to a temperature issue or something happening, a vaccine needs to get put aside to maintain the safety for individuals. To be able to say out of the thousands and thousands of vaccines that it's one or two is not a fair ask, because when we're administering vaccines, these are normal processes. I can confidently tell you that there is no discarding of vaccines unnecessarily in any situation with the COVID-19 vaccine. And I hope that what Rep. McEntee shared is the key message on how we are handling any leftover vaccines. The Rhode Islanders need to be clearly assured that no vaccine is being unnecessarily wasted.
Thank you.
So, follow up. So, second question I had. So I heard representative from Central Falls mention that when he's at the clinic, that the clinic was prioritizing 65 and over. When you're talking about providing the vaccine to highly dense communities, are these vaccines being prioritized to general population, or are they falling within the priority set? So similar, 65 and over, or something along those lines, or are they just everybody in the community? Is that available to everybody within the community?
It is, and I'll start and then let anyone from the team add. It is why I shared the data from our more significantly impacted communities on race and ethnicity. Going just by age actually is ineffective for certain communities. There are Latino and African American populations that are not just disproportionately impacted at age 65 and older. They are getting hospitalized at age 30, 35, 40, 45. We shared that data with you. And that's why on a pilot basis, we are really targeting not just the older in our high density community, but also some of those who are disproportionately impacted and at higher risk of hospitalization, because that's our number one key. Whatever the data shows us about who is at higher risk of being hospitalized or dying is what we're using to inform how we're vaccinating.
Thank you. Representative Mary Messier. Mary, unmute yourself.
I received, or I read an email today from a Smithfield school teacher, and she's 64 years old, and she has a class of 21st graders who she's in close contact with daily. And she's afraid that phase one, the way it's being done, it may extend for several months. And she strongly supports that teachers and school staff get vaccinated in phase one, especially if there is so much support for opening the schools again. When do you see this possibly with the teachers and the school personnel?
Thank you for that, and please relay our appreciation for her service, and certainly ensuring that our particularly younger students are able to get in-person learning. I'm hopeful that this presentation and discussion will help equip all of you with answering this question, because it is a critical one. As we go forward, it's an important one. Number one, once we have the supply, the timing for when we will be able to get to her will be, accelerated. In lieu of the type of numbers that we are getting with vaccine, it does stretch out the time. Number two, we do intend to ensure that anyone older in our population gets to be able to get access to the vaccine sooner rather than later, as long as we have the supply. So as I mentioned earlier at the press conference, There's full agreement with the federal government's report yesterday that we should start vaccinating 65 and older. They just need to give the vaccine that will allow us to capture that 190,000 number group of our population. And then number three, in our school settings in particular, she can be reassured that that given the structured environment, we have not seen overwhelming number of outbreaks with multiple generations of transmission of COVID-19 in our school settings. The governor shared earlier today the pilot study that we had done within the last couple of months, testing over 900 students and staff in schools in a pilot across the state, including our high density communities. And the percent positivity was less than 1%, less than 2%. So that is the reassuring factor to know that in lieu of the vaccine supply issue, we're doing everything to ensure that teachers, students, staff in the school community are just as safe to be able to go to school, teach, and learn. We are also adding the asymptomatic testing approach in place for teachers and students right now at this time. So we believe that there's enough to be able to cover for the individuals, particularly those in the school setting who are at much less risk of hospitalization or death due to COVID if they were to contract it, compared to some of the other populations that we are prioritizing right now. We wouldn't want to remove the vaccine for those from those individuals and give it to other individuals who have a significantly lower risk of hospitalization.
Thank you. Representative McGraw.
Thank you. I do have a question, but I will just start with reiterating what Representative McEntee has said. I have also worked at one of the MedPod clinics for the East Bay regional program and was there at the end of the clinic where we actually stayed an extra hour and a half after the clinic to be sure that any extra vaccine doses were administered. So we were calling people that were on a wait list and waiting for them to arrive because we did not want to leave the clinic with any vaccines wasted. That being said, my question actually, it's actually more of a suggestion. I think the Department of Health has done a really good job of keeping people informed about the spread of COVID with daily updates regarding the number of cases, the number of hospitalizations, the number of fatalities. That information is readily available in so many different ways on the website, and I appreciate what they're doing. And with so many questions around vaccine distribution, I'm wondering if we couldn't do a similar type of reporting for COVID vaccine distribution to let the public know how much vaccine we're receiving, how much has been distributed, keep them on top of exactly what populations have been vaccinated, maybe if possible, even what population of those populations, a percentage of that population, so that the people of Rhode Island have a sense of where we are in the vaccine distribution process and can take comfort in knowing that it is moving through in an efficient manner.
We agree with you 100%, McGaw. We, now being a few weeks in, we really focused early on making sure that our operations and our systems would be strong no matter what came our way. The first week, we suddenly found out we weren't going to get the number of vaccines we were allocated. So we are feeling confident in that system now and are really focused now on building out the communication more effectively so that Rhode Islanders can understand, why are we seeing this on CDC and seeing something else here, and how many are getting administered, and how to describe like the complexity of it. Takes 7 to 14 days between when we order it and receive it. It's like a complicated message. So now that we have our some rhythm going. Our whole focus this week, with the credit to our amazing communications team who's been working so hard to help respond to this, is to make sure, and data team, is to make sure that we have the numbers and can provide it in a way that helps the public understand. And that's why sessions like this are valuable, because we're equipping you to help us in doing that. When people are like, what's going on? They're, throwing out vaccine. No, Rep McAtee, Rep McGaw, like, we're actually seeing it. And kudos to you both for volunteering to administer. Thank you for that. But the more you all can help us in making sure that the true message is out there about what's going on in a very complicated, extremely dynamic realm, I think the better we can be. Our first was to make sure the system was strong. We have that confidence. Now let's help others understand how strong it is in spite of, all types of other messages that are out there.
Thank you. Representative Norrie.
Thank you, Chairman. Dr. Scott, I'm just, again, thank you for being here and with your staff. So I have a couple quick questions. Rep. Messier had brought up with teachers. I too have been contacted by my local community teachers and asked, they're being told they're 3 to 4 months down the road for being vaccinated. Based on what you had said, teachers through the study that you did, 1 to 2% in schools. So safe to say, yes, they're 3 to 4 months down the road based on the vaccine being received.
So there's 2 answers to your question. No matter when we get the vaccine, teachers should feel safe now with being able to go back to school. In terms of the amount of time before we get to teachers, it's fully based on what supply we get. If we get more than what we're getting right now, we can move times up, which is what our hope is, with more vaccines being produced. So if nothing changes or worsens, then yeah, we're looking at the type of time frame that you said. But hopefully with the pressures and people, the federal government understanding, there'll be an increased supply and the time frame will be shorter. But either way, we'll be ready, and either way, teachers are safe with what they have now.
Okay, thank you. Also, shifting gears, and again, I know this has been talked about a lot, but my question may be a little bit different. So again, with CVS and Walgreens handling the congregate care settings, what is the plan for the older population that we're discussing, or we've discussed a lot about? How will they sign up, and is there an actual plan in place? Do we have it that we can publish to show, because apparently from what I'm hearing, PCPs aren't aware, and the confusion is, how do I get my name in the hopper, right, so that they know how to contact me? So that, I guess that's kind of a concern for people that aren't in a congregate care setting.
Yep. I'm going to get started quickly, but definitely share this with my colleagues in answering. Specific to your mention of the outpatient providers, I had stated earlier that they've already received a survey that will allow us to reach out to them. And we've since corrected that. The survey is intended to go out on Friday for the primary care providers and outpatient providers to be able to give us the information, so that as we are moving up the starting time earlier, we'll have a way to reach them. It'll still be incremental over time because it's over 65,000 individuals, and we're only getting a few thousand that we're able to attribute to this. But we want to make sure with every group that there is a clear way to for them to get enrolled for vaccinating. And so with that, I'll pass it on to Alicia, Trisha, or others to thank you.
Good afternoon. So we've been working with the Office of Healthy Aging to try to identify the best locations to vaccinate people. where they access services or that are familiar community-based fixtures. So for the regional pods, for instance, or for those of you who have been involved with municipal pods in the past, they're typically at schools, but we're really going to try to maximize adult daycare sites and senior centers because they are more accessible, they are more familiar, and they have staff who are familiar to a lot of the members of the community who are 65 and over. We have just begun working with the Rhode Island Health Center Association. We heard from some of the health centers that they would be interested, now that they're fully enrolled as COVID vaccine providers, in vaccinating their patients who are 75 and older. That's where we currently are in our phase 1.5 structure. But we have been, again, working through the Long-Term Care Coordinating Council, the Office of Healthy Aging, to again access the resources that will help us support ensuring that we get all of the people who we need. And then to Dr. Alexander Scott's point, if we get to a point where we require a sign-up opportunity, we can engage in that way as well. But we really want to nail down the details of the locations and the geographic distribution of that to ensure that we have safe and accessible places for people to come and get vaccinated. We've also done a survey of all of our home health agencies to ask who would be willing to vaccinate people in their homes, because we know that there are some folks who can't leave their homes, or it would be harder for them to leave their homes. So we will be working on a twofold process for that, not only engaging them in the process to be vaccinators, but also to help us identify where there are folks who will need that service if, as a specific home health agency, they don't provide that service.
Okay, thank you.
Thank you. Let's see, I get, Representative Fogarty.
Just a follow-up on that. I know when people were scheduling to get their testing done, that there was some problems with the scheduling. I know that you addressed that. You were trying to get all the places set up and then the sign-up opportunities. Are we going to be addressing that? Because there seemed to be a lot of people couldn't get on, that type of thing. I'm just trying to make sure that we have a smoother rollout with the vaccination part of it when we get to the general population. I think that would help everybody. So if you could address that. Thank you.
We have been working with a vendor for the regional pods, so for folks who signed up through that process up to this point in time. It is the first time we have implemented a process. If you know, during H1N1, just as an example, we didn't need a sign-up process. We didn't have social distancing. We also, when we opened municipal pods, we didn't have resource limitations either. And so we were able to have people just pile up out the door and stand in line chatting with each other while they waited to get their vaccine. And that's a huge deterrent for us in this event, because we know that COVID is so easily spread. And so this is admittedly our first implementation of that process. We have, as you mentioned, a lot of lessons learned from the testing rollout. We are utilizing a different vendor that was built from an immunization program several years ago, and we are working every day with that vendor. We actually purchased an additional resource to be able to work with that vendor every single day to try to smooth out any of the issues that get identified. So can we assure you that it will be perfect? Of course not. But we are working, I assure you, every single day we identify some nuance that we want fixed in that process so that we can make it as efficient and as easy to use as possible.
Thank you. Representative David, please.
Thank you, Mr. Chairman. Dr. Scott, could you help me out a little bit? I'm trying to figure out how to explain in my best bedside manner. I'm a machinist by trade, so bedside manner isn't my thing. Could you help me out? How do I explain to a grandmother in Warwick or Burrable, why it is that, a young man or a young woman in Central Falls is getting the vaccine?
I think she explained it pretty clear. I think you did a good job, Doctor. Do you have another question? Representative.
I just know, I know she explained it with the numbers and everything like that, but I just don't think folks at home in our district necessarily understand the numbers, proportions and things like that. So, again, I was just wondering if recommendations if I get questions. So
that's why you're a rep. You can put them together. You can speak to your people. Next question. Representative Chippendale.
Thank you. At the risk of sounding like a broken record, one of the areas that I have great concern about, and all of the things that we've been discussing here today really bolster my concern even further, is a population that has not been discussed, and that is the employees and partners at DCYF, because those folks interact with people from every group, vulnerable groups, vulnerable zip codes, if we're possibly able to qualify that way, vulnerable races, whatever the criteria we're using. DCYF employees take children and move them from house to house, sometimes on a nightly basis. In nowhere have I seen anything concrete that will assuage the concerns of not just the dedicated, overworked, understaffed people at DCYF, but also the residents that they serve. Again, that's very concerning. I would like to know, where do they fall on this hierarchical chart of who gets what when?
I'm glad that you asked so that we could address your concern. There's only but so much you can actually put in detail out in terms of what populations are covered when we are presenting the table. And so Alicia is happy to share all of the plans and processes in place for our DCYF and other state colleagues that are on the front line.
Sure. So we have spent a lot of time over the past several years discussing behavioral health parity, and that access to behavioral health care should be and coverage for behavioral health care should be the same as it is for medical care. And so that's an embedded part of our mantra inside the Department of Health. So we sleep and breathe in that space. And so when we chose the term outpatient provider in 1.4, when we put this out initially, it was an all-encompassing term. And again, people did not see themselves reflected in that term, which is why we've updated the slide to reflect more of who we intended in that group. It was not that we didn't include behavioral health, or as you're discussing, some of the similar outpatient services that are provided through DCYF. Those are all included, and it was our intention from the start to include them. As Dr. Alexander Scott stated, we just didn't list every potential group because we thought that that was representative. And that was a mistake on our part, because we have learned that people do not find that they are reflected in that. So to your point, Representative Chippendale, we've been in close contact with the leadership at DCYF to try to identify a prioritization schema of their staff who are forward-facing. We agree. We feel that way about home health. We feel that way about the behavioral health providers who are providing services in multiple locations. I got that question a little while ago as well. So it is our intent that in 1.4, those providers will be vaccinated.
That is definitely encouraging to hear that. Due to the transient nature of their work, again, going from house to house, sometimes day to day, seeing multiple children, et cetera, multiple communities, is there any thought being given to perhaps elevating them up to perhaps even where we have right now, frontline nurses, et cetera? It would seem, again, to make sense, just because of the transient nature of the work that they do. They're constantly in and out of houses, and frankly could pick up a disease. And just with what we know now, during the period where they could transmit it, they could conceivably visit dozens of homes and spread that. Is there any conversation on your level around perhaps elevating the urgency for those staff?
That group begins next week, Representative. And again, we've been in close contact with the DCYF leadership for the entirety of the DCYF staff. As individual state agencies, we've had to do our own ranking based on, again, that level of interaction with members of the public or going into homes, so that we know and understand where even state agency staff, and of course inside the EOHHS family, that's very prominent, so that we can ensure that we are not just touching programs, but really truly understanding who's out in the field. All of our partners Child Protective Services comes to mind, right? So again, they sometimes walk into situations unannounced, which puts them at even higher risk. So they rank higher than other folks who may be going home to home than others. So again, we've been working with the leadership and we've begun the vaccination process for folks who the leadership agrees have been at the higher risk in an ongoing schema.
Excellent, thank you. And I am going to shut up after this one last question, and it's just more of a curiosity. I know that AstraZeneca and J&J are working on their own vaccines, which will be, I'm guessing, will be approved by the FDA. It certainly sounds like they're leaning that way. Is there any game plans being put together? Because I know that those are also very different as far as the administrations. I think one of them doesn't even need to be refrigerated. Is there any sort of a game plan being developed in anticipation of those, so that when they come, we already have the ground plan and we can execute it?
When we discuss them as part of our overarching vaccine search plan. And the issue is that while we know what, like you mentioned, some of the considerations, the Johnson & Johnson vaccine at this moment in time, for instance, is just one dose. How fantastic would that be to not have to coordinate 2 doses? So, that will play into our planning for that. But the challenge is what the data that we don't have is who those vaccines are the most effective in. And so if we find out that any of the vaccine menu is more effective in groups who are 65 and older, for instance, or in children, or pick a group, any group, we're going to need to shift our entire strategy to ensure that we insert that vaccine in the right place for the right populations, and then adjust the rest of the vaccines around it. So we are prepared to do that. We, of course, have laid the groundwork for those conversations, but because there are so many possible scenarios that we can't predict, again, as I've said before, we try to put as many chess pieces on the table as possible so that we're ready to utilize those whenever a new vaccine or a change in the guidance comes into play for us.
That's a great answer to hear. I'm so happy to hear that. Thank you all very, very much.
Representative Giraldo.
Thank you, Chairman. So as I had mentioned earlier, I really think your presentation lays out the data in a really easy to read, easy to understand way. It talked about the prioritization, it talks about the anticipated timelines, and I know those can shift. And I also asked you to talk about some of the environmental factors that go into why things are the way that they are. And I wanted to know, is this presentation or is this data easily available on your website, or is that something that can be sent to us? Because it's our responsibilities as representatives to be able to answer those questions. I'm sure that Representative Place may not be the only one hearing those sort of questions being posed. And I think if we are equipped with that data, it'll really help us when we have these conversations with people who are questioning where they fall and why they fall the way that they do.
Absolutely. Neil Heitman is at your service, so we'll make sure you have all the slides that you need from this presentation and beyond. We appreciate the partnership to help respond to the questions that are out there.
Thank you. And Chairman, if I may, one more, not really a question, more of a comment. Some of my colleagues, I know Representative Messier and Rep. Norrie brought up the concerns that many school teachers have, understandably so. And while I understand that school spread isn't really that prevalent, I do want to just convey the difficulty of opening up a school with the in-person, with the amount of quarantines that are happening just because of the prevalence of the virus. And so I understand that there hasn't been that many documented cases of school spread, and that's something to celebrate and to be proud of. But as someone who works in a school, it can be very difficult to keep in-person instruction happening when there's some have to quarantine for 7 days, 10 days, 14 days, etc. Thank you.
Thank you. We're getting close to closing this out. And I've got one last question or 2 last questions. And I'd like to know, is there a vaccine approved by the FDA or the CDC for children? And that's number 1. And then I wrote down this other one on herd immunity. What does the Rhode Island Department of Health believe It is vaccination rate, or where we should be with herd immunity, and how many people need to be vaccinated to get there.
Dr. Chan, are you good with both?
Yes, ma'am. So regarding the vaccination for children, so the two vaccines are only approved for folks 16 or 18 and older. There's a number of ongoing studies at the moment looking at 12 to 16 or 18-year-olds. So we expect to have some more data in the future. There's no trials that I'm aware of looking at younger than 12. I'm not sure, Alicia, I know that sometimes you're a little bit more, you're also up to date on that. In regards to the herd immunity question, I think that's the million-dollar question. Available modeling and past experiences suggest that we start to see herd immunity around 50% of the population, keeping in mind that herd immunity is a combination of both natural immunity and vaccination. So it's not just the vaccine, it's also the percent of the population that has previously had it. So 50% is where we begin to expect to see some, but ideally we want to see that at 70% or above. So those are the numbers, 50 to 70%. It's what's cited in literature. It's what Dr. Fauci is on record saying.
Thank you. And for the members here, any other questions? Raise your hand. Okay. I want to thank everyone for showing up this evening. We'll be back again to deliver another message to our communities. Mind you, we're working for our communities. I understand that. So with that said, this is not a reflection or to put down anybody else, that just because I'm not in your community, you're not in my community. We're here to help every community that we represent. With that said, I want to say thank you to everybody who attended, and we'll see you again. Keep up the good work. Godspeed.
Thank you.
Thank you.
Yeah.